So I'm going to try and explain to you what the difference is between EPAP, IPAP and CPAP. Essentially, to try and explain that, I'll first talk about what happens in the upper airway and what pressure we need in the upper airway across the breathing cycle, because if you can understand that, then it's pretty self-evident what the difference is between these two settings. So in this part of the diagram, as we're breathing out, we're effectively blowing air from the lungs out through the upper airway, and it actually inflates or blows open the upper airway, so that the pressure we need to keep an airway open when we're breathing out is less than what we need when we're breathing in. So the pressure that's needed while we're asleep to keep the airway open at the end of breathing out is called EPAP. So think of it as expiratory positive airway pressure, but that's abbreviated to EPAP. Now, when we go to breathe in and draw air in through the upper airway, we actually generate a sucking effect in the upper airway, which then closes the airway. So naturally, you'd expect you need a higher pressure to keep the airway open during the breathing in part of the cycle. And turns out that's true. And that's called the inspiratory positive airway pressure, so the pressure needed to keep the airway open when we're breathing in. And there's normally a minimum difference between the pressure to keep the airway open on breathing out and the pressure to keep the airway open on breathing in of 3 centimetres of water pressure. And that difference, the difference between expiratory positive airways pressure and inspiratory positive airways pressure, is called pressure support. So in PAP terms, that'd be called PS, pressure support, so minimum pressure support of 3. Now some people, particularly people who are overweight or got very collapsible airways, need a lot more pressure support than that, because when they go to breathe in, the airway is very vulnerable to collapse, so the inspiratory pressure has to be quite a lot higher than the expiratory pressure. And that difference can be as high as 15 centimetres of water pressure. So we'll usually have pressure support on an auto BiPAP machine set at a minimum of 3 and a maximum of 15. So why actually bother? Why look at expiratory pressure, inspiratory pressure and make it more complicated? Well, there is some data suggesting it's a bit more comfortable for patients. So if we're setting the pressure most of the time to be able to cope with this, where the airway is most vulnerable to collapse, as we go to breathe out, we're going to feel the strength of that pressure and find it a bit harder to breathe out against that resistance. And that's one of the things people describe with CPAP that can be uncomfortable for them, breathing out against that pressure. It's also one of the things that can lead to air in the stomach, aerophagia, is trying to breathe out against a higher pressure coming back in. So that's one of the rationales for using a lower pressure in expiration, EPAP, and a higher pressure in inspiration. So hopefully I've been able to give you an idea of the difference between EPAP and IPAP, but think of it about what's happening in the upper airway, and I think that allows you to get past some of the confusion with the different terms, and think of it as we breathe out, we still need some pressure to keep the airway open because people with sleep apnea have a narrow airway, but as we breathe in, we need a higher pressure to keep the airway open. And the difference between those two is what we call the pressure support. So when setting up a BiPAP machine for patients, what are the settings that we want to look at on the machine? Well, the parameters we're able to set are expiratory positive airway pressure, EPAP, the maximum inspiratory positive airway pressure, so that's IPAP, and the difference, the minimum difference, so minimum pressure support, and the maximum difference, maximum pressure support. The way I'd manually determine the EPAP, and this is what I do in the sleep laboratory, and I'll come to what the auto machine's actually going to do in the home, which is more relevant to what you're doing. Manually in the laboratory, what we'll do is gradually increase, we'll have IPAP and EPAP exactly the same, so we're using it like CPAP. We'll increase the pressures until we get to enough pressure that even at the end of breathing out, the airway's nice and open so that apneas are controlled. Then we'll set that as our EPAP. And then we're gradually increasing the pressure support, so the difference between EPAP and IPAP, so that until we get to a point where when people are breathing in, there's not snoring, there's not flow limitation. And then we know what our ideal IPAP is, and we know the difference between our set EPAP and our set IPAP, and that gives us our pressure support. Now, when you're using a BiPAP Auto in the home, it actually does all of that work for you. But at least if you understand how I do it manually, it gives you an idea of what it's actually doing. So BiPAP Auto will increase the EPAP until apneas are managed. Then it'll gradually increase the difference between EPAP and IPAP to manage hypopneas, flow limitation, subtle airway narrowing and snoring. The difference that you need between these is going to differ between the type of sleep you're in, what stage of sleep, what body position, so it's not always the same. And that's where with the auto machines we set these parameters. The minimum pressure support, 3, maximum pressure support, I usually keep that default at 15. So don't be intimidated by the BiPAP Auto, it's actually pretty simple to set the parameters, and try and think of it in this type of framework of what's the minimum expiratory positive airway pressure, what's the maximum IPAP, the minimum pressure support and the maximum pressure support.
For the A to Z of sleeping well, head to the Hub, sleephub.com.au.